when we look at a map, whether it's a zoning map of a city or like a meteorological map of a weather system, the borders usually make sense. You know,
Right, they're defined by something physical.
exactly, something tangible. Like a river dictates exactly where the city line ends,
Yep,
or a massive mountain range just stops a storm front from moving any further east.
it's entirely logical.
Yeah. But then you look at the human body and you quickly realize that disease doesn't usually respect those kinds of borders. I mean, a rash just spreads outward indiscriminately, and infection travels wherever it wants.
It disseminates, yeah. A typical pathogen or, an inflammatory response just moves wherever the blood or the lymphatic system takes it.
It takes the path of least resistance.
Exactly, which usually looks incredibly chaotic on the surface of the skin.
It's totally chaotic. But today, we are looking at a condition that defies that chaos, a condition that draws this incredibly precise, almost eerie map on the human body, entirely sparing everything just like millimeters outside its borders.
It really is fascinating.
So, welcome to today's Custom Deep Dive. And to you, our listener today, the learner, we are so thrilled to have you with us as we navigate, honestly, a massive stack of medical guidelines.
A very heavy stack today.
Right. Today, our mission is to unpack a complex, highly impactful, and vastly misunderstood dermatological condition called vulvar lichen sclerosus, or LS.
And we are pulling directly from the National Clinical Guidelines of the UK's BASH and BSSVD, alongside clinical atlases and patient advocacy resources.
We really want to figure out exactly how this disease operates.
Yeah, and while this condition is chronic and it carries an incredibly heavy physical and psychological burden for the women who live with it, the first step toward reclaiming comfort and health is understanding its boundaries.
Which are so distinct.
They are. There's a distinct logic to how this disease manifests, even if the physical reality of it seems terrifying at first glance.
And that logic starts with a highly specific, highly visual diagnostic hallmark, a shape. The medical sources literally refer to it as the figure of 8 pattern.
Yeah.
So what exactly are we looking at when we talk about this shape?
Well, to understand lichen sclerosus, you really have to visualize the blueprint it draws on the skin. So LS predominantly affects the anogenital region.
Okay.
And when the disease becomes active and begins to spread, it doesn't just fan out in a circle. It follows a very specific anatomical pathway.
Like a designated route.
Exactly. It typically starts at the top, at the clitoral hood and the labia minora.
The inner lips of the vulva.
Right. From there, it travels downward through the perineum, which is the space between the vulva and the anus, and then it continues down to encircle the perianal area.
So tracing that pathway, a loop around the vulva, pinching in at the perineum, and then another distinct loop around the anus.
It literally forms the shape of a figure of 8.
An interconnected, continuous figure of 8.
Yes, exactly.
It's like a highly localized weather system or a distinct burn zone on a map. I mean, it's fascinating in a slightly unsettling way that an internal disease knows exactly where to draw its boundaries.
It is.
It establishes this figure of 8 and leaves the normal skin just millimeters outside of that zone entirely untouched.
And the visual of where it stops is crucial because it's not just about where the disease travels, it's about where it absolutely refuses to go.
Right.
That figure of 8 pattern strictly stops at the vaginal mucosa.
Meaning the inside of the vagina.
Yes. Lichen sclerosus never affects the internal lining of the vagina. The inflammation halts abruptly right at the entrance, the introitus.
Wow. Not even a little bit.
Not at all. And from a diagnostic perspective, this is a massive clue for dermatologists and gynecologists.
Why is that boundary so important for a diagnosis?
Because there's a similar, often confusing autoimmune condition called lichen planus, which does attack the internal vaginal mucosa, causing severe internal erosions.
Oh, I see.
So if a doctor sees the classic figure of 8 on the outside, but the inside of the vagina is completely spared, that boundary line heavily points to lichen sclerosus.
It's like the disease hits a different type of cellular terrain, the mucosa, and just gives up. So if the skin inside that figure of 8 is completely contained, what is actually happening to the cellular architecture within that specific zone?
Well, the visual and textural changes within those borders are dramatic. The clinical atlases describe the skin turning an ivory or porcelain white color.
Okay.
It loses its elasticity entirely and becomes incredibly thin and wrinkled. The medical texts constantly fall back on the same analogies, describing the skin as looking like cigarette paper or crinkled cellophane.
Okay, wait. I read through those same clinical atlases, and there's a glaring contradiction in how they describe this texture.
Oh, really?
Yeah, the sources say the skin becomes incredibly thin and atrophic, like wet tissue paper. But in the very next paragraph, they list hyperkeratosis as a symptom,
Right.
where the skin gets thick, scaly, and warty. How can the skin be tearing like cellophane and thickening up into scaly plaques at the exact same time?
It sounds impossible, right? But it's actually a dual-natured response driven by the body's desperate attempt to protect itself.
Okay, walk me through that.
So the primary disease process causes the epidermis, the top layer of the skin, to basically lose its structural architecture. It atrophies.
Right.
It becomes violently fragile. And because the tissue is so thin, the tiny blood vessels underneath lose their cushioning.
Oh, man.
Yeah, so you see deep purple bruising, which doctors call ecchymosis or purpura, happening from almost no friction at all. The skin simply shears.
The cellophane tearing.
Exactly, and that extreme fragility brings an agonizing, intractable itch. We are talking about severe pruritus that typically peaks at night, completely destroying a patient's sleep cycle over months or, honestly, years.
Which is horrific.
It is. So because the patient is scratching this incredibly fragile skin, or just because the skin is constantly tearing and trying to heal from basic daily movement.
The body initiates a defense mechanism.
Exactly. The body responds to the constant trauma by sending keratinocytes into overdrive, overproducing keratin in localized patches to shield the broken skin.
Tries to build armor.
Yes, that's the hyperkeratosis. You end up with this microscopic landscape where the overall skin is paper thin and tearing. But dotted within that figure of 8 are these thick, raised, scaly plaques of defensive tissue.
Wow. So within this one single shape, you have extreme fragility, painful tearing, which the sources call fissuring,
Right.
deep bruising, and thick, scaly plaques, plus an itch that keeps you awake all night.
Yeah, and the physical toll leads to intense soreness and burning. Every time the fragile skin splits into a fissure, it stings, especially when it comes into contact with urine.
Right, which you can't avoid.
Mm.
So what is driving this? I mean, if the body is building armor to fight off the tearing, but the tearing is caused by the body's own skin thinning out, what's initiating this figure of 8 burn zone in the first place?
The underlying mechanism is deeply hidden, but the primary driver is friendly fire. Autoimmunity.
Okay.
While the absolute definitive cause of LS is still listed in the guidelines as unknown, the immunological evidence strongly points to the immune system attacking the body's own structural tissues.
Yeah, specifically, I saw the sources note that between 60 to 80% of women with vulvar lichen sclerosus have circulating antibodies that are actively attacking a protein called extracellular matrix protein 1, or ECM1.
Yes.
And extracellular matrix protein 1 sounds like some kind of structural support system.
It is. You can think of ECM1 as the mortar between the bricks of your cells.
A mortar.
Right. It's essentially the biological glue that holds the skin's dermal architecture together and gives it resilience.
Oh, I see.
So when the immune system erroneously attacks that glue, the skin loses its integrity, thins out, and becomes that fragile cigarette paper.
Okay, but let me challenge that autoimmune theory for a second based on the demographics and the data.
Sure.
If this is just an autoimmune issue, like rheumatoid arthritis or lupus, which can strike at various ages, why does the data show lichen sclerosus peaking in 2 very specific, distinct groups? Prepubertal girls and postmenopausal women.
It's a great question.
I mean, the disease almost entirely skips a woman's reproductive years. Doesn't that indicate this is a hormonal issue, not an immune one?
It looks entirely hormonal on the surface, given that bimodal age distribution. But if it were purely a hormonal deficit, we could just prescribe topical estrogen creams and the disease would be cured.
And I'm guessing they don't.
They don't cure it at all. Estrogen doesn't stop the immune attack. That is how we know the immune system is the one actually dealing the damage, which is why the guidelines describe LS as multifactorial.
Okay, so how are the hormones and the immune system interacting here then?
Well, estrogen is what signals the vulvar tissue to stay plump, highly vascularized, elastic, and robust. It maintains the fortress walls, so to speak.
Right.
When estrogen levels naturally drop, like in childhood before puberty or later in life after menopause, that tissue naturally thins out. It loses its biological armor. So when those aberrant ECM1 antibodies show up, they're attacking a fortress that already has its gates wide open.
The immune system pulls the trigger, but the low estrogen environment is the loaded gun.
Exactly. It's what makes the skin susceptible to the attack.
So we have the blueprint of the figure of eight. We have the physical reality of the cigarette paper skin trying to armor itself with hyperkeratosis.
Mhm.
And we have the underlying perfect storm of immune antibodies attacking the ECM1 mortar in a low estrogen environment.
It's a lot.
It is. But I imagine a lot of adult women, and certainly parents of young girls, might just write this intense itching off as a stubborn yeast infection or diaper rash for a long time.
Oh, absolutely. That delay in diagnosis is incredibly common, stretching into years for many
Look,
patients.
oh, years.
Years. And that prolonged delay is where the disease does its most insidious work. Lichen sclerosus doesn't just sit on the surface of the skin causing an itch. The chronic inflammation actively remodels the human anatomy.
Remodels it. I know the medical term used in the atlases is resorption.
Right. As the chronic inflammation rages unchecked within that figure of eight, the body's continuous frantic healing response goes haywire, leading to profound architectural scarring. Over time, the labia minora, the inner lips, can completely resorb. They don't just shrink, they disappear, fusing flat to the midline of the body.
I was trying to visualize how inflammation actually deletes anatomy, and the best analogy I could come up with is a plastic zipper.
Oh, that's a really good visual.
Yeah, if you take a lighter to a plastic zipper, the teeth melt. And if you leave it to cool, it fuses together into a solid, flat block of plastic. You can never unzip it again.
Right.
The natural separate pathways are permanently melted and closed off.
And when that melting and fusing happens higher up, it affects the clitoral hood. The hood, which is supposed to freely retract to protect the clitoris, becomes inflamed and seals completely shut.
Oh my goodness.
The clitoris becomes permanently buried underneath a rigid wall of scar tissue. And because that space is sealed, natural dead skin cells and bodily debris get trapped underneath the fused hood, forming a clitoral pseudocyst.
Which must be incredibly painful.
Intensely painful, and highly prone to secondary infections. The tragedy is that a patient might go to the doctor with this painful cyst, and the doctor might just treat the infection with antibiotics, completely missing the underlying autoimmune disease that caused the hood to fuse in the first place.
That's devastating.
Yeah.
And the functional impact of losing your anatomy like that, it just destroys a person's quality of life.
Completely.
Because as this scar tissue progresses downward, it causes introital stenosis, right? A severe narrowing of the vaginal opening.
Yes. The tissue loses all its stretch, which leads directly to severe dyspareunia, which is the medical term for extremely painful sexual intercourse.
Right. For many women, intimacy becomes physically impossible because the tissue simply tears rather than stretching.
It is a devastating loss of intimacy, function, and bodily autonomy. But the architectural damage isn't just limited to adult women.
No, it's not. The pediatric resources highlight a detail that is just heartbreaking.
It really is.
Because the figure of eight pattern extends down to include the perianal area around the back passage. In prepubertal girls, the skin in that loop becomes so fragile that just passing a normal bowel movement causes those painful fissures, literally tearing the perianal skin open.
And a young child doesn't understand autoimmune pathology,
Right.
They just know that going to the bathroom is agonizing, so they instinctively start to withhold.
Yeah.
They hold their bowel movements in to avoid the tearing pain.
Which leads to severe chronic constipation. I mean, you might have a 6-year-old child being treated for months by pediatric gastroenterologists, taking daily laxatives, undergoing dietary changes,
Yes.
and facing immense psychological stress around the bathroom, when the actual root cause is an undiagnosed autoimmune skin condition tearing their anatomy apart.
Exactly. And a pediatric misdiagnosis like that doesn't just prolong the child's pain, it allows the underlying inflammation to continue unchecked.
Right.
And the longer that inflammation smolders, whether in a child or a postmenopausal woman, the higher the chance of the most severe complication listed in these guidelines.
The risk of malignancy.
Yes. The guidelines are very clear on this imperative. Women with vulvar lichen sclerosus have an estimated lifetime risk of just under 5% of developing squamous cell carcinoma.
Which is a serious type of skin cancer.
Right, arising directly within those figure of eight lesions.
A 5% risk of cancer is significant. And this brings up a huge question regarding the treatment protocol.
Okay.
We know the standard treatment is a topical steroid cream to suppress the immune system and stop the itch.
Yes.
Does treating the itch actually lower that 5% cancer risk? Or does the cream just make the patient more comfortable while the underlying cancer risk stays exactly the same?
This is perhaps the single most vital takeaway from all the clinical guidelines we've reviewed, and it directly addresses the fear many patients have about using strong medications. Effective, long-term disease control with topical steroids actively reduces the risk of malignant transformation.
So it's not just symptom relief. It is active cancer prevention.
Yes, absolutely. If you halt the chronic inflammation, you halt the continuous frantic cycle of tissue damage and cellular repair.
I see.
It's that constant, chaotic repair cycle where cells are rapidly dividing to heal the fissures over and over again that eventually leads to copying errors, cellular mutations, and ultimately squamous cell carcinoma.
Wow.
By calming the immune system and stopping the inflammation, you're protecting the cellular DNA from mutating.
So what is the gold standard strategy to stop this immune response in its tracks?
The absolute gold standard across all the international guidelines, BSHH, BSSVD, and others, is an ultra-potent topical steroid.
Okay.
The most commonly prescribed is clobetasol propionate, often known by the brand name Dermavate.
Ultra potent. I mean, that implies a very heavy medical hammer.
It has to be heavy. You're fighting a deeply entrenched, highly localized autoimmune response. But because it's so potent, the application has to be incredibly precise to avoid side effects.
Right.
The guidelines outline a strict tapering rescue regimen.
So how does a patient actually execute this taper?
Well, patients are taught to use exactly a fingertip unit.
What's that?
It's defined as just enough ointment to cover from the tip of an adult index finger down to the first crease. It's about 0.5 grams of ointment.
Very specific.
Very. They apply that highly controlled amount to the figure of 8 area every single day for 1 full month.
Hit it as hard as possible for 30 days to break the cycle.
Yes. Then the deliberate taper begins. For the second month, they apply it only on alternate days. And for the third month, they drop it down to just twice a week.
Why do they have to taper off, though? I mean, if the inflammation is that aggressive, why not just keep hitting it with the daily hammer to make sure it stays gone?
Steroid phobia is a real issue, and patients often worry that steroids thin the skin. And they are correct.
Wait, really? Yes. Ultra-potent steroids, if used continuously over long periods, can cause the skin to atrophy, which is the exact symptom we're trying to fix in lichen sclerosus.
Right, right.
So the goal of the taper is to hit the inflammation with a massive hammer initially to put the immune system to sleep, and then slowly back away to a minimal maintenance dose.
Just enough to keep the immune system dormant without causing chemical damage to the skin.
Exactly. That maintenance dose, maybe once or twice a week indefinitely, keeps the ECM1 antibodies in check.
Makes sense.
And alongside the steroids, the patient resources heavily emphasize avoiding any external irritants that could provoke the skin. That means no bubble baths, no scented body washes, and no tight friction-causing clothing.
Yeah, they recommend using soap substitutes and heavy emollients like thick moisturizers to constantly protect the skin barrier.
Exactly.
Because genital skin already has a weaker barrier function than the rest of the body. And when it's under autoimmune attack, you really have to baby it.
You do. It requires a fundamental shift in daily hygiene and lifelong management. Well, to summarize our journey today, we started with a striking visual clue. A literal figure of 8 drawn on the body, mapping out an eerie zone of extreme destruction that entirely spares the internal vaginal mucosa.
Yes.
We looked at how this condition, driven by a perfect storm of a low estrogen environment and an autoimmune attack on the ECM1 structural mortar, turns the skin to fragile cigarette paper.
While simultaneously forcing it to build thick plaques of reactive hyperkeratosis.
Right. And we saw how, if left unchecked and misdiagnosed, it acts like a melted plastic zipper, permanently fusing anatomy together, burying the clitoris, destroying sexual function, and causing agonizing chronic constipation in young girls.
But we also saw the path forward.
Yeah.
While lichen sclerosus is chronic and currently incurable, a strict, properly managed tapering regimen of ultra-potent steroids does vastly more than just stop the nightmarish itch. It halts the anatomical destruction, prevents the labia from resorbing, and actively prevents the cellular mutations that lead to cancer. With compliance to the guidelines, patients can return to a normal, functional quality of life.
It's a powerful reminder that while the body's internal chaos can be terrifying, understanding the map it draws gives us the precise tools to fight back.
Definitely. And as we wrap up this deep dive into the guidelines, there is one final lingering mystery that the medical literature still cannot fully answer.
Ooh.
Something for you, the listener, to mull over. We know that up to 80% of these patients have antibodies actively hunting and attacking extracellular matrix protein 1, That's the mortar holding the skin together.
Right.
But ECM1 is not just located in the vulva, it is distributed extensively throughout the entire human
It's
body.
in the vocal cords, it's in the skin of our arms, it's everywhere.
So why does the immune system choose to mount this devastating, highly localized attack almost exclusively in that highly specific figure of 8 zone? What undiscovered, hyper-specialized cellular microenvironments exist within our immune system that dictate exactly where a war is fought on the landscape of our own skin? Why there and absolutely nowhere else?
It all comes back to the map, the borders. There is so much we still don't comprehend about why the human body draws the lines it does. But asking the question is the first step toward the next medical breakthrough. Thank you for joining us on this deep dive. Until next time, keep questioning the map.